Very good morning to all of you present here. So at the outset, I would like to thank all the speakers who have agreed to be a part of this instruction course. So through today's instruction course, we are going to highlight different scenarios which can lead to refractive surprises, ranging from preoperative examination, diagnostics, planning, communication errors, to actual errors in execution. So now, and once all the talks are over, we'll be taking up all the questions. So without wasting much time, we will start with the first topic, which I'll be presenting. I'm Dr. PAVITRA Patel Balkrishnan, a cataract and a refractive surgeon working at Saidi Eye Clinic and Crystal Vision Laser Center, Mumbai. So I have combined the first two talks as Dr. Anand Parthasarathy couldn't join us due to personal reasons, and his talk will be covered by Dr. Nikhil Balkrishnan. So the topic for my presentation is, oops, I missed it, clinical examination and diagnostic errors. So this picture speaks for itself. There is no margin for error in refractive surgery, and therefore a meticulous history-taking clinical examination and a good diagnostic evaluation is a must before any refractive surgery. So before starting any eye examination, a skillful history taking is required because the patient may not himself say everything related to him. So obtaining a thorough medical and ocular history is important to look for diseases which can potentially affect the outcomes of LASIK surgery. Systemic diseases such as diabetes, autoimmune diseases, collagen vascular diseases, and history of keloids may alter wound healing, and it can also result in more haze formation post-PRK surgery, and therefore these patients should be chosen only after careful evaluation. Now, ocular conditions like ocular herpes, peripheral keratitis may reactivate after LASIK surgery. So asking about these conditions conditions is of utmost importance, and missing this important history can lead to disastrous outcomes. So also, history about any strabismus surgery in childhood is very important, as again the patient may feel, patient may have a recurrence of his squint after LASIK surgery. And oftentimes patients will forget or not think that a surgery done in childhood is as important as surgery done in the later life. Also, having a family history who has a history of keratoconus may give the suspicion for the possibility of keratoconus, and therefore these patients should be also carefully examined and screened for keratoconus. Now, in clinically, to begin with lid examination, it is important to look for signs and symptoms of meibomian gland dysfunction. If the lid disease is present, pre-treatment is very much necessary for this patient. Next, attention should be given on the conjunctiva and cornea, investigating for the signs of dry eyes and punctate keratitis. And for this, staining with vital dyes like fluorescein and lissamine green are important to quantify the amount of dryness. Next, it is also important to look for any corneal irregularities or abnormalities like anterior basement membrane dystrophy, which again may interfere with the LASIK surgery. Next, we should be looking at the corneal scarring or any old vascularization, which may signal old infections. Anterior chamber and iris examination is equally important, again suggesting of some old viral infection. The posterior or uveitis. The posterior cornea should be inspected for signs of endothelial dysfunction, and the crystalline lens, of course, should be carefully examined for any signs of cataract formation. Also, a complete dilated fundus evaluation is necessary. Now, especially in high myopic patients, it is important to perform a peripheral retinal examination to look for any retinal tears or hole, and which may need treatment prior to LASIK surgery by a retinal specialist. Now, moving ahead, there are different diagnostic errors that might occur during the pre-surgery evaluation. These could be refractive errors, topographic errors, pachymetry errors, errors which can arise because of different pupil sizes and because of dry eyes. Now, usually some of us only check manifest refraction before doing a refractive procedure. But cycloplegic refraction should be a mandatory test for all our patients, as it will help identify patients with latent hyperopia as well, and it will avoid patients from getting overcorrected. So if this is not taken into consideration, it may lead to suboptimal outcome. Now, generally, we advise our patients to remove the soft contact lenses at least 24 hours prior and RGP lenses 48 hours prior, basically before checking the refractive error. So that, why do we do that? Because it might alter the shape of the cornea temporarily, and again, it might give you a slightly different refractive power. Next, we move on to topographic errors. So as you can see here, with change of different head postures, there is a change in the astigmatism which is noted. So it is very important for the person doing the topography scan to check whether the forehead is properly touched to the front bar, and the head is not tilted. So this is the display that we get after capturing the image on a topolizer machine. Now, before exporting the data, it is again very crucial for us to see whether the scans are of optimal quality. So first and foremost, we look here. Here, this P, it signifies the preferred image for a contour treatment. R signifies good iris registration, which is again required for cyclotorsion, mainly required for advanced eye tracking. And here, the AA, it signifies area analyzed. It again has to be, all the three parameters basically has to be in green in color. Next, we get the pupil size here. Now, the pupil must be of similar size when you capture the topography and when you treat the eye to avoid any decentration. Now, if the scans are less than perfect, the screen will display a red X and show which quadrant or quadrants have insufficient data. And this means that the scan has to be repeated. And if these scans are taken for your surgery planning, definitely the outcomes will be suboptimal. We can also assess the quality of the scan by checking the camera image. By clicking on the Placido disc here, we can check for the continuity of the red and blue lines or the Myers. And then we measure the distance at which the first discontinuity, as you can see here, of the Myers is seen. Normally, we keep an optical zone of around 6 to 6.5 millimeters. So we should make sure that the captured scan here is of good quality, at least in that particular zone, by checking all these parameters. Next, we check the center of the pupil, the corneal vertex, and the limbal markings. Now, the center of the pupil again and the corneal vertex are important basically to know about the angle, kappa, which is the difference between the pupillary and the visual axis. Now, here we can see both the center of the pupil and the corneal vertex are well aligned with each other, and the limbus is also well defined. So, after doing all of these, we select 4 different scans of the same eye, like seen here in the image, and then we compare the scans to see for any difference in the K reading. Now here, for instance, if you, this is an image, so I won't be able to show it to you, but if you put your cursor to any one point here, it will show the difference between the two scans, the K reading difference. So if this difference, if it is less than 0.75 diopters at a given point, the scans are comparable and can be very well taken for the planning. Now, there is a likely possibility when we do the topography scan on a Placido disc-based topographer like topolizer, that which do not give the posterior elevation map, we are likely to miss out on FFKC in suspicious cases. So in any suspicious cases, doing a Scheimpflug scan is very important to avoid missing on FFKC. Now coming on to the pachymetric errors, the ultrasound pachymetry here measures only the central corneal thickness, whereas the OCT pachymetry measures corneal thickness in all the 4 quadrants. So what is the advantage of this? The advantage is that first it will help in screening criteria for keratoconus, and also it will help customize LASIK surgery, which is mainly our contour surgery. So this is a screening criteria for keratoconus. It has 4 parameters. First one is the difference in the superonasal and inferotemporal should be less than 45 microns. Difference in the superior and inferior if it is less than 45 microns. Minimum corneal thickness if it is less than 470 microns. And the minimum minus maximum if it is less than minus 100 microns, it is likely a case of keratoconus. Now, sometimes you also do get patients wherein the overall pachymetry reading, as you can see here, is well within the normal range, but the epithelium mapping shows a very thick epithelium of around 80 to 90 microns. Therefore, epithelium mapping is an, again, important tool, especially when you are planning for a PRK surgery to avoid under or overcorrection. Evaluating the pupil size, especially in the dark area, will allow better informed consent. Why? Because patients with larger pupil sizes again will be at risk of developing glare and halos for post-LASIK surgery. Now, the last criteria which we should be not missing out clinically is dry eyes. So, for example, if you have a patient with moderate MGD associated dry eye pre-operatively, if you know that, and if the same patient undergoes a refractive procedure, there are chances of him developing post-operative diffuse lamellar keratitis. So in such cases, it is always better to treat the patients by giving them 3 sessions of IRPL therapy, no financial interest here. And this will thereby help in reducing the MGD-associated dryness, and it will in turn give us better optimal outcome post-surgery. So to summarize, a good history taking and a clinical examination is of utmost value. Diagnostically, we should be definitely taking, we should be measuring cycloplegic refraction for all our patients. A good quality topo scan by using a Scheimpflug imaging whenever in suspicion. Use of a OCT-based pachymetry, especially to rule out keratoconus, and when you're planning for any customized contour procedures. Scotopic pupil size to be measured for every patient, and managing dry eyes or MGD-associated dry eyes prior to refractive surgery is of utmost value. Thank you.